Hello and welcome everyone. Today the topic we will discuss is the vasopressor and inotrope use in cardiogenic shock. A very confusing topic as to what should be used if the patient is having a shock which is of cardiac origin. Now, the definition of cardiogenic shock is a condition with insufficient cardiac output to meet the body's metabolic needs, leading to a severe end organ hypoperfusion. The systemic impact is tissue hypoxia, inflammation, and vasoplegia, which is a part of the SIRS response. The compensatory mechanisms are endogenous sympathetic stimulation, which increase the heart rate and the myocardial contractility, peripheral vasoconstriction to raise the systemic vascular resistance and the mean arterial pressure. Adverse effect of the compensations is increase in the cardiac output, myocardial oxygen demand, and increase in the filling pressures. There is a reduction in the coronary perfusion pressure. Now, the necessity for hemodynamic support is crucial to restore the cellular metabolism and prevent worsening of the ischemia and potential shock spiral leading to a circulatory collapse and death. Mind you, cardiogenic shock is not equivalent to reduced contractility or heart failure. Chronic heart failure is not equivalent to cardiogenic shock. It is an event which has happened suddenly, resulting in reduction in the cardiac function, resulting in tissue hypoxia. So you must keep in mind before you start therapy. Now, the therapeutic goals is rapid identification and treat the underlying cause of shock. Improve the tissue perfusion, oxygenation, and maintain acceptable cardiac output and blood pressure. The treatment strategies is to use vasoactive agents, temporary mechanical circulatory support in select cases. So the epidemiology. Traditionally, defining a cardiogenic shock is been very difficult due to varied clinical, biochemical, and hemodynamic definitions used in various trials and guidelines and societies. Now, the harmonization of the definition is done by Society of Cardiovascular Angiography and Intervention, where they induced a pragmatic classification system to diagnose cardiogenic shock across a spectrum of disease, from at risk to fulminant circulatory collapse. Now, the validation of the diagnostic system has been validated across multiple clinical groups, including cases with or without acute myocardial infarction in intensive care unit, and those with CS following out of hospital cardiac arrest. So, mind you, the most common cause of cardiogenic shock is myocardial infarction. So 90% of the cases of cardiogenic shock that you're going to see is because of acute myocardial infarction. So the importance of uniform definition is required because it is crucial to understand the exact epidemiology and to make our clinical trials designed in such a way so that we can make a direct comparison of the outcomes instead of worrying about what the definitions were. Now, the incidence is around 408 cases out of 100,000 hospitalization in the US. The commonest cause, as I said, is mostly acute coronary syndrome, and it has a huge cost factor which is associated due to the hospital stay, and the mortality rate range from 50 to 60% in 1 year. Now, the lack of data in pre-hospital settings make the exact incidence very difficult to diagnose because again it is one of the commonest cause of cardiac arrest out of the hospital setting also. So in that case also the mortality rate reaches somewhere around 50%. The effectiveness of pre-hospital interventions have not yet been analyzed, and no such intervention has been found which is very effective in reducing mortality rates. Now, vasoactive agents are very important here to maintain the hemodynamics and to maintain the perfusion before we do the reperfusion strategy or any specific intervention that will reverse the cause of cardiogenic shock. Now, The prevalence is around 25% of the patients in ICU receive at least one of the vasoactive agents, and the percentage increases to over 90% if the patient is admitted with cardiogenic shock. So norepinephrine is increasingly being used to support hemodynamics in cardiogenic shock, and there are various comparative studies which have shown this. The association of mortality, the need of vasoactive medication is independently linked with short-term mortality. There is a stepwise increase in the risk of in-hospital mortality with increasing number of vasoactive agents administered. Dose-dependent mortality is also existing because as the dose increases, the risk of mortality also increases. Now, observed excess mortality with the use of vasoactive events is a concern. However, this may be confounded by the severity of the disease. It is not that the vasoactive agent which is killing the person, it is the reason of the shock and the requirement of the vasoactive agent to maintain the hemodynamics is which causes the death. Now, obviously, we need further evaluation to see how vasoactive agents work in an environment where we can effectively and very easily use devices like the mechanical circulatory devices, though they are still not very common right now. They may be in the future. So coming to the pharmacology of these agents. The study of vasoactive agents started in 1893, where glandular extracts were done and their vasoreactivity were tested. They were divided into three main categories: the vasopressors that increase the systemic vascular resistance and the mean arterial pressure. The next is inotropes, which improve the cardiac output and the contractility. The inodilators, which have a mixed response of inotropy as well as arterial vasodilation. Now, the impact of hemodynamics has been quite well studied in the 50s and the 60s, where in vivo studies were done and they found exactly which drug does what, and various receptors and their interactions were noted. Now, recent studies including animal models show that catecholamines like epinephrine, norepinephrine, and dopamine increase the cardiac output, MAP, and the right atrial pressure in a dose-dependent manner. This challenges the strict categorization of these drugs as either vasopressors or inotropes. Now, myocardial oxygen consumption is usually increased by vasoactive medications, potentially causing further injury in the case of cardiogenic shock, where, as we have already discussed, the most common cause is a myocardial ischemia. And myocardial energy needs are met mainly through oxidative metabolism. So basal metabolic rate constitute 10 to 20% of the myocardial oxygen need, and the remainder is heart rate, contractility, and the systolic wall tension. So the heart rate is the largest contributor to the oxygen consumption, and usually the vasoactive agents also increase the heart rate. Now, factors like coronary perfusion is dependent on the pressure gradient, the perfusion time, and the coronary artery vasomotor tone. Now, the supply-demand mismatch occurs in the case of cardiogenic shock because of the hemodynamic collapse, the cardiac filling pressures, the heart rate variability, the vasomotor tone, and the myocardial consumption. Now, commonly used vasoactive drugs and their classes are catecholamines. They act through the alpha-1 and beta and the dopaminergic receptors. The beta-1 is results in increased cardiac output and because of increased systolic calcium and phosphorylation troponin I, improving the contractility, lucitropy, and chronotropy. The vascular effects are that it causes vasoconstriction by the alpha-1 receptor, resulted by increasing the MAP. The beta-2 activation causes vasodilatation. Specific agents are norepinephrine, epinephrine, norepinephrine, and dopamine. Now, phosphodiesterase inhibitors, they inhibit the PDE3, thereby increasing the cytosolic CMP levels. The increased inotropy in the cardiac tissue, vasodilation of the blood vessels, enhanced cardiac output, and reduced afterload is the major effects. The caution is they should be carefully used in patients with renal impairment due to the risk of toxicity. Next is calcium channel sensitizers like levosimendan. They enhance the contractility through cardiac myofibril cardiac calcium sensitization and has peripheral vasodilatory effects as well. It also inhibits PDE3. Now, long half-life or because of the active metabolite prolongs the hemodynamic effects. The next is arginine vasopressin antagonists. They act via the V1 A receptor and V2 receptors. They cause vasoconstriction and water retention. The use is mainly to improve the systemic vascular resistance to improve the cardiac output. Now, they may ameliorate the vasoplagia and reduce the catecholamine resistance. Finally, is the guanyl cyclase and the nitric oxide synthetase inhibitors, that is Methylinblue. It initially is used for methemoglobinemia, is now considered to be treatment for refractory vasoplegic shock. It inhibits nitric oxide mediated cyclic GMP production, leading to increased vasoconstriction. Caution should be used in patients with SSRIs, that is a risk of serotonin syndrome, and G6PD deficiency. Now, these are the various catecholaminergic and other agents which act on various receptors in the blood vessels. The catecholamines through the alpha receptor cause vasoconstriction. Similarly, the vasopressin also causes vasoconstriction by the V1 receptor. However, catecholamines, when acting on the beta 2 receptors, and levosimendan acting on the ATP potassium channel, cause vasodilatations. So various classes of catecholamines and other vasoactive agents result in different vasoactive responses. They can either cause constriction or dilatation. Now, regarding the action on the cardiac myofibrils, norepinephrine, dopamine, epinephrine, all these things act on the beta 1 receptor, resulting in cyclic GMP activation and improving contractility, increased leucotropy and chronotropy. And as you can see here, the milrinone and the phosphodiesterase inhibitors, they act here, thereby inhibiting this particular enzyme and resulting in activation of contractility. Levosimendan acts further down directly on the myofibrils, whereby improves the calcium sensitivity of these myofibrils. Now, evidence of use of these vasoactive agents in cardiogenic shock. Now, multiple RCTs have been done, leading to various societal recommendations. There have been multiple consensus statements and meta-analysis. Now, the variability is lot of them is there. The European guidelines endorse norepinephrine or dobutamine as a first-line treatment in cardiogenic shock. American are less definitive, with varied recommendation across various American Heart Association guidelines. Now, initial treatment goals is focusing on the perfusion of the vital organs. For that, you need to augment the MAP and the cardiac output, particularly important in the AMI cardiogenic shock due to the link between the low systolic blood pressure and the increased mortality risk. Now, dopamine versus norepinephrine, it was tested in the SOAP2 trial, where dopamine had safety concern because it caused increased arrhythmia and higher mortality rate with no effect in the improvement. Norepinephrine is advocated over dopamine for hemodynamic support in cardiogenic shock with hypotension, based on this particular evidence. The next is norepinephrine versus epinephrine. The Optica CC trial compared epinephrine with norepinephrine in AMI cardiogenic shock, revealing no difference in the MAP, cardiac index, or stroke volume. The epinephrine was associated with worse metabolic acidosis, increased lactate, higher heart rates, and greater myocardial oxygen consumptions. Now, increased rates in refractory CS in epinephrine treated group led to early trial termination. A meta-analysis indicated a significantly greater risk of mortality with epinephrine treatment. Concerns with epinephrine use. Now, epinephrine's lack of benefit in hemodynamic parameters and is associated with increased myocardial oxygen consumption, higher risk of mortality in refractory CS, raises concern of it as a first-line treatment. And further data is needed to establish norepinephrine superiority over epinephrine. The next is treatment of cardiogenic shock with preserved blood pressure and low cardiac output state. Now, in this, there is a lack of RCTs because none of the inotrope agents or the inodilators have been tested in this particular setup. Now, commonly administered inodilators include the dobutamine, milrinone, and levosimendan. Now, effect of inodilators is while increasing the myocardial contractility and leucotropy like traditional inotropes, they reduce the cardiac afterload through vasodilatation. Now, the capital DOREMI study, it is a single-centered, double-blind RCT comparing milrinone and dobutamine in ICU patients with cardiogenic shock. The study found no difference in the primary composite outcome of these various parameters like mortality, cardiac events, and non-fatal MI. Now, consider for use in normotensive CS and low cardiac output state, both dobutamine and milrinone can be considered as a fast line therapy. In case of severe renal impairment, dobutamine is to be preferred. So considering the previous usage, it is and lot more experience with dobutamine can be considered as superior to milrinone in this particular setup. Now, treatment of refractory hypotension, this presents a significant challenge in cardiogenic shock in the context that severe metabolic acidosis leads to reduced responsiveness to catecholamines. Here, vasopressin and Methylinblue, due to the relatively preserved vasopressor effect in acidosis, may be considered as salvage therapy in catecholamine refractory vasoplagia. Now, these are various guidelines which have been given for management of hypoperfusion with cardiogenic shock, but mostly, as you can see, the recommendations are based on very low level of evidence, and even if there is evidence, the most of the recommendation is for hypotensive patients. Regarding low cardiac output state, they have not yet been able to tell any particular agent which is of benefit. The only thing that you can see is dobutamine has been recommended as a 2B recommendation in the European STEMI guidelines. But mostly, if you look at the overall, it is norepinephrine throughout. For low cardiac output, very few recommendations are there. Now, regarding a stepwise approach, how to use vasoactive therapy in cardiogenic shock. So first, based on two phenotypes, you need to see what is your patient. My patient is having hypotension, that is a systolic BP less than 90 or MAP less than 65. Or more than 30 reduction in MAP with evidence of hypoperfusion. Then the patient is low cardiac output and preserved blood pressure, that is the second group. Now, initially correct the hypotension. This is the first step by addressing the low cardiac output state with ionodilator therapy. Now, role of mechanical circulatory devices, the decision is not clearly defined as of now, but if the cardiogenic shock persists, you can and should use mechanical circulatory support devices. So initially what you do is you give vasopressors, maintain the BP, and then you with the ionodilators you target to improve the cardiac output. Now focus is, as I said, on norepinephrine because the use is always recommended as the first therapy, and this is the first thing that you should do to maintain the hemodynamics first. Now assess the response to therapy. Once you have started, do invasive monitoring, do a continuous blood pressure monitoring, target a MAP of more than 65. Although exactly what should be the target is still being debated because the data is limited, because nothing is coming actually from the cardiogenic shock per se. There is a very important role of pulmonary arterial catheter, though recently there have been a lot of studies which have shown its proper usage can be of benefit because of the old trials which had shown negative impact, but most of the studies were done where the use was not proper, where the user was unable to interpret the data. That is when the complications happened. But if the user is able to interpret the data, it has got a very, very important role in guiding the therapy in cardiogenic shock. Now, biochemical assessment can be done with serum lactate levels to see if the perfusions are improving. Now, serial measurements should be done of various parameters to see which parameters are improving. As I have my monitors, as I am continuously measuring my PA catheters, the arterial pressures and the lactate, so I can serially see whether my patient is showing signs of improvement or not. Regarding the future, we need more high quality RCTs in cardiogenic shock patients to know exactly what therapy needs to be given. There is a need for more generalizable data because most of the patients currently are already in the ICU who have already received treatment, then only we are recruited them. Now, there have been two seminal trials which are being done, that is the capital DOREMI 2 trial, which is looking at the role of ionodilators in the initial management of cardiogenic shock, aims to provide insight into their effectiveness. The second is the Levo heart shock trial. It is a French study evaluating the addition of levosimendan or a placebo in cardiogenic shock already treated with noradrenaline or dobutamine, aiming to compare the utility of inodilator therapy with traditional catecholamine agents. Now, pre-hospital studies are also there. Given the high rates of pre-hospital cardiac arrest, the PANDA trial, for example, will compare epinephrine and norepinephrine in pre-hospital setting, focusing on the 28-day mortality to guide the first-line catecholamine therapy. The other is the mechanical circulatory support versus mechanical therapy. The use of mechanical circulatory support devices like the Impella can be of benefit and VECMO can also be used to improve the safety and efficacy. Serial trials are underway to assess the mechanical circulatory devices and the comparison in medical therapy alone. As we go ahead, we will see that there is a role of pharmacological agents, and these agents should be used properly, and they are the cornerstone of management because they need to be used to support the hemodynamic first, then only we can start with other therapies. The current guidelines are limited by lack of robust data, highlighting the urgent need for high quality trials in future. Thank you.